First, I want to thank Joel and Tomas and Deborah and Bonnie for a panel that encourages us to approach research with attention to history, context, geography, and reflexivity. We have several more panels scheduled for our conference today. And if you will be attending, as Crystal mentioned, if you will be attending the COVID-19 risk factors and farm worker engagement panel, you do nothing, you stay right here. It'll begin shortly on this Zoom link. And but if you'll be attending the data collection and COVID-19 pandemic panel, please follow the link for webinar 2, which has been placed in the chat. We do want to give folks about a minute just to get there if they haven't already, or if you're planning on staying.
I think it's time to get started because it's like 11:37.
Right. So if you're in the right, so if you are interested in attending the COVID-19 risk factors, it's this Zoom link. If you are interested in attending the data collection in COVID-19, you go to webinar 2. So
and I don't know if Crystal placed it in the chat, so we may need to get it because folks are asking about the link, and I don't think it's here.
Crystal is putting it on the chat.
Okay. Thank you, Anna. All right, so welcome everybody. We have Spanish language interpretation, so I'll pause for a moment so that announcement can be made. Maybe the interpretation is on the other panel. Is that what happened? Okay. So if you need interpretation, please let us know. We have a couple of interpreters with us today. So I want to start by saying thank you for being here with us today. This panel is titled COVID-19 Risk Factors and Farm Worker Engagement. We're lucky to have presentations from 4 researchers doing exciting and innovative work on farm worker health and engagement. Before we get started, though, I wanted to remind folks that the presentations should be about 10 minutes each, so we can have 10 minutes at the end for a Q&A, and a few minutes for a break before the next panel. Actually, we should have like 15 minutes for Q&A and a few minutes break for the next panel. So to that end, I'm going to be holding up these cards. Actually, you can't very well see that it says 5 minutes, 2 minutes, 1 minute. Okay. So if you see my face disappear, that means I'm trying to hold up a card and speed things along. And I'll let you know if we're getting close to time, just so that there's enough time for Q&A at the end. Okay, so our first presenter is Dr. Maria Mora. Dr. Mora is an assistant researcher with the Center for Environmental Research and Children's Health at UC Berkeley, and an associate professor at the Central American Institute for Studies on Toxic Substances at Universidad Nacional in Costa Rica. Her talk is titled Prevalence, Risk Factors, and Impact of SARS-CoV-2 Infection Among Farm Workers in Monterey County, California. Go ahead, Dr. Mora.
Thank you. I'm just going to put my slides on slideshow, and I apologize at Dr. Flores, but I can't see your face. So if you could just let me know if I'm running behind, I would appreciate
Absolutely.
that. Hello, everybody. Good morning. Thank you for joining our webinar. My name is Maria Mora. I'm a researcher at the Center for Environmental Research and Children's Health at UC Berkeley. And I want to share with you some results from a study that we conducted in collaboration with Clínica de Salud del Valle de Salinas. And I led the study with Drs. Leonard and Dr. Eskenazi from the School of Public Health at UC Berkeley, and Dr. Max Cuevas from Clínica de Salud del Valle de Salinas. So as I mentioned, this study was undertaken as a collaboration with Clínica de Salud, which is a federally qualified health center. We recruited study participants between July 16 and November 30th. Farm workers who were aged 18 years or older, who were not pregnant, who had engaged in agricultural work within the 2 weeks preceding enrollment in our study, which is a window that we later expanded to since March due to the end of the agricultural season, who received a diagnostic SARS-CoV-2 test at Clínica de Salud del Valle de Salinas at the time of enrollment, and who were sufficiently proficient in English or Spanish to give consent and complete study procedures were eligible to participate in our study. We were able to enroll 1,115 farm workers in our study. About half of them were recruited at clinics from Clínica Salud del Valle de Salinas, and the other half were enrolled at community outreach events, such as vaccination, flu vaccination campaigns, food donations, and housing visits. As part of the study procedures, we required our participants to consent to release the TMA test results from Clinica to UC Berkeley, to provide a blood sample to measure IgG antibodies against SARS-CoV-2 proteins, to provide a saliva sample to measure other pathogens in upper respiratory tract, such as pneumococcus, to allow us to measure their weight and height so we could calculate their BMI or body mass index, and to answer a detailed questionnaire by phone. This questionnaire allowed us to collect data on sociodemographic and occupational factors, but also risk factors for SARS-CoV-2 infection. It also included the USDA Food Insecurity Scale, the Patient Health Questionnaire 2, and the Generalized Anxiety Disorder 2, because we were interested in the impact of the pandemic in this vulnerable population. All study participants received a $50 gift card for being enrolled and completing the study procedures. So briefly, I want to describe who were our study participants. So most of them were Latino. Most of them were born in Mexico, were non-married or living as married. About half of them had an annual income of less than $25,000. They were male and had a primary education or a lower educational level. The average age was 40 years, and their average time in the US was about 20 years. Most of them spoke Spanish, but we did have 10% of our study participants reported speaking indigenous languages at home. 42% of them were classified as obese, and remember that this was based on their weight and height that we measured at the time of enrollment. 14% were hypertensive, and 11% reported as self-diabetic. 30% of them were living in overcrowded households. About 80% reported a possible exposure to someone with COVID-19 at home, whereas 14% of them reported a possible exposure to someone with COVID-19 at work. About 75% of them worked in the field, and 34% of them reported commuting to work with non-household members. Very important to mention that more than half of them reported working from home, reporting going to work with symptoms of COVID-19. And about a quarter of them said going to work because they were worried about losing pay or losing their job. So we posed ourselves 4 questions in our study. The first of them is, what is the prevalence and clinical profile of SARS-CoV-2 infection amongst farm workers? The second one, what are the risk factors of SARS-CoV-2 infection among farm workers? The third one, what is the impact of the pandemic in this population? And the fourth one is their vaccine hesitancy among farm workers and why. In this presentation, I'm going to cover the first 2 research questions listed in the slide. The third one is going to be covered by Dr. Brenda Skenazy in her presentation at 1:30 in webinar 1. I hope you can attend her talk. And the fourth one is an analysis that we're currently conducted with data, not only from our Monterey County study, but also with data that we collected together with the Madera County Health Department and together with researchers who conducted a study on farm workers in Fresno County. So 30% of our farm workers, or the study participants that we enrolled in our study, tested positive for SARS-CoV-2 infection. It's important to mention that we observed differences in the TMA positivity prevalence, depending on whether we enrolled them at the clinics or we enrolled them in outreach events. About 27% of the overall study population reported symptoms in the last 2 weeks, and we found that those who were symptomatic had a higher prevalence of current infection than those who were asymptomatic. And when we looked at differences among those symptomatic who were recruited in clinics and those who were symptomatic who were recruited in outreach events, we found a higher positivity rate among those who were enrolled in the clinic. In this graph, you can see changes in the prevalence of the current infection over time. As I mentioned, we enrolled our study participants between July and November. However, it's important to point out that these prevalences are weighted for recruitment venue because, as I mentioned before, we saw differences depending on clinic and whether they were recruited in clinic or outreach events. And it's also important to mention that these prevalences were higher than those observed at the county level, but very consistent with the rates that Clínica or Clínica Salud del Valle de Salinas saw in their farm worker population that they were testing for free starting in June 15 last year. In this graph, you can see differences in the prevalence of seropositivity. So again, this is historic infection measured using antibodies in blood. And these are also weighted for recruitment venue. And you can see differences over time. And I want to bring your attention to the fact that the seroprevalence doubled between July and November. So it went from 10% to 21% at the end of the study period. When we looked at the risk factors for SARS-CoV-2 infection amongst farm workers, we looked at risk factors for current infection. So this is among the study participants who provided us or for whom TMA test results were available, and also risk factors for historic infection, which are the farm workers who provided us with a blood sample. So in this graph, you can see the risk ratios for different factors that were associated with current infection. We found that those farm workers who had a primary education level or lower, who spoke indigenous languages at home, who said to be exposed to COVID-19 at home or at work in the last 2 weeks, and who worked in the fields had a higher risk of current infection than their reference categories. Notably, when we looked at seropositivity or risk factors for seropositivity, and this is about 1,000 of the study participants that we enrolled in our research, we found that those who were obese, who self-reported as diabetic, who lived with children less than 5 years at home, who lived with unrelated roommates in crowded housing or in crowded households, and who reported a possible exposure to COVID-19 at home since the beginning of the pandemic had a higher risk for being seropositive at the time of enrollment. It is important also that we noted or we observed that those who lived in other towns than Salinas, those who worked indoors, and those who reported that their employers were providing them with information on how to protect themselves at work had a higher risk of having a previous infection for SARS-CoV-2. So I briefly want.
Okay, I just want to let you know it's 1 minute, but you're on
Thank
conclusion
you.
screen.
So I just want to summarize what we found and what I just shared with you in our slides. So we found a current infection prevalence that was extremely high at the time of our study period. And this is among Monterey County farm workers between July and November 2020. We found that many farm workers were going to work while they were sick, many due to concern of job or pay loss. We observed that current infection was associated with education, with speaking indigenous languages at home, with working in the fields and being exposed to COVID-19 at home or at work. We observed the seropositivity doubled between July and November, reaching over 20% in our study population. And we found that historic infection or seropositivity was associated with crowded households, living with children or unrelated roommates, living with a COVID-19 case or somebody who was suspected to have the disease, being obese, and having diabetes. So briefly, I just wanted to mention that it's clear to all of us that COVID-19 has pulled back the curtain on a series of inequities that farm workers have been exposed to or suffer in our communities or farm worker communities, including the lack of affordable quality housing, food insecurity, irrational immigration policies, hierarchies in the farming sector, and the lack of trust between farm workers and their advocates and growers. However, it is important to point out that although COVID-19, the pandemic, has shown a lot of inequities in this population, it has also shown that we're capable to do many good things when we work together. And I just wanted to share with you a picture that was taken at a COVID-19 vaccination event in Salinas Valley. And this was an event hosted by Clínica Salud del Valle de Salinas together with the grower shipper associations. So with the Association of Growers in the county and with nursing students from Harnell. And so they have been able to conduct multiple vaccination events, and together the employers and community trusted clinics have been able to bring all farm workers and get vaccinated. And these have been very successful. And as I mentioned, they have been coupled with educational campaigns with nursing students to try to deal with the misinformation surrounding vaccination, COVID-19 vaccines. So I want to thank our colleagues at UC Berkeley and Clínica Salud del Valle de Salinas, including our staff who worked tirelessly on this project. Also want to thank our funders, the Innovative Dynamic Institute and Clínica Salud del Valle de Salinas. And of course, thank you to all the farm workers who have toiled during this pandemic to put food in our tables. Here are our emails, and I welcome any questions at the end of the other talks. Thank you.
Thank you, Dr. Mora. And we'll go ahead and hold off on questions. I know we can use the chat function, but let's go ahead and hold off on questions until the end, just so we can give our full attention to the following presenters. Our second presenter is Dr. Ann Cheney. Dr. Cheney is an assistant professor in the Department of Social Medicine, Population, and Public Health at the University of California, Riverside School of Medicine. Her talk is titled Engaging Latinx Farm Working Communities in COVID-19 Testing Clinics.
Thank you very much. So my name is Ann Cheney. I am faculty in the UC Riverside School of Medicine. And I am the principal investigator for this study, but I want to recognize that this is a collaborative effort, as I'll talk about. And one of my key collaborators is Maria Mora, who is our community researcher. So today, in the brief 10 minutes that we have, I want to talk about the population of Latino farm workers in the eastern Coachella Valley, which is located in the inland desert region of Southern California, to discuss the COVID-19 spread and risks amongst this farm working population, and then to present study design, capacity building, and findings from a rapid qualitative study on COVID-19 in Latinx farm working communities in the eastern Coachella Valley, and then of course, take a moment to talk about policy implications. Okay, trying to navigate. All right. So we know that racial ethnic minority groups are at a disproportionate risk for COVID-19. Thinking about when we began this project, which we submitted a grant, this is funded by a local foundation, Desert Healthcare District. We were asked actually by the organization to work on our infrastructure that essentially is a student-led clinic that has really strong collaborations with the local farm working community to be able to think about how could we address the really high numbers of COVID-19 cases among Latino population, but specifically in Riverside County, thinking about this being an area where there's a great number of farm workers in particular, but knowing that within that context, in that, we could say in summer of 2020, understanding that Riverside County had the second highest cases of confirmed cases and deaths in the state, and that it was a significant risk for farm workers within the Eastern Valley, of which I'll show a graph in a moment. But thinking about in the COVID-19 pandemic, that Latino farm workers, they are essential workers. This has been heightened and brought forth, and that they have to decide every day to leave their homes and provide food for the nation. So this is an image of the Eastern Cotella Valley. I've been doing work there for about 5 years now, community-based participatory research. The Eastern Cotella Valley is one of the richest agricultural areas in the world, like many other areas of California, and it contributes as much as 6 million in annual agricultural production. It's also one of the most impoverished areas of California and very well known for its undocumented and underinsured Latino immigrant population that lives often in poverty and works in the fields. So this is an image in July. These two graphs illustrate a difference of 1 week. This image illustrates the coronavirus and COVID-19 infection in the Eastern Coachella Valley. This is the same time when we began our research project. This is a project, as I'll get to in a moment, that includes multiple arms, one of which is research. I'd like to highlight these two communities, Thermal and Oasis. Thermal is one of the largest communities in the Eastern Coachella Valley with migrant farm working population. And Oasis as well is a very large farm working community that also includes a very large indigenous population, Purepecha community, which is from Michoacan, from the state of Michoacan in Mexico. So our project aims, as I said, there were multiple arms to this, included engaging members of farm working communities in COVID-19 testing, to disseminate COVID-19 public health information in both Spanish and Purépecha, and then to conduct research on perceptions about COVID-19 testing services and future vaccine uptake among Latinos and farm working communities in the Eastern Cotella Valley. This presentation specifically will focus on aim 3, which is the research. So we used a rapid qualitative approach, and from November to December of 2020, we conducted this research. Our main question was, what factors shape the use of COVID-19 testing services and vaccination among Latinos and farm working communities in the Eastern Cotella Valley? The work that I do is community engaged, and for this project in particular, we use community engaged participatory research approaches, which emphasizes shared decision-making, mutual trust, and collaboration. So we trained, including myself and my community partner, community researcher, we trained promotores to recruit participants, facilitate focus group, and also to analyze data. We conducted 7 virtual focus group via Zoom with 6 to 10 participants in each focus group. They were facilitated by promotores with assistance from medical students and pre-medical students. And we used a rapid analysis, including template and matrix analysis. So essentially we created summaries of the focus groups. We then condensed the text data into cells in Excel matrix, and we looked for themes and patterns across the focus groups. And this allowed us to essentially have a cross-case comparison for our interpretation. The characteristics of the participants: a third were farm workers, most identified as female, most identified as Latino or Hispanic, and were between the ages of 25 to 54. 17% identified as Purépecha. And all lived in agricultural communities along the sea. So while they may not have been at the moment a farm worker, they lived in farm working communities, and many of which were also living and lived in farm worker households and families. We asked questions, including, aside from the focus group, we had a sociodemographic questionnaire at the very end that included some questions around the coronavirus. And we asked about how they felt affected by the coronavirus, as well as their fears or their understanding in their relationship to the virus. 83% indicated that they felt affected by the virus, and 74% indicated they were afraid of the virus. Okay. The following themes, patterns, we found to shape attitudes, knowledge, and behaviors related to the use of COVID-19 testing services and ideas around future vaccination. Misinformation, lack of trust in institutions, particularly the government, public health officials, and medicine, and then insecurity related to employment, loss of employment, and then fears of deportation. The idea of misinformation, so poor or wrong information, we found contributes to confusion and disbelief in the virus. COVID-19 and vaccination, and comparisons were often made to the flu, which minimized the gravity of the virus. So as one participant said, I had thought at the beginning that it, referring to the virus, was like the flu season. It was going to pass by easily, so we didn't focus on paying attention to public health guidelines. The theme of lack of trust in institutions. So we heard from participants the lack of confidence in government entities, particularly the previous administration, government administration, and public health, due to the political context and strong belief that government and public health were working together to kill people. For me, in the beginning, really early on, when the virus was just starting, I was hearing everyone, they said it, spread the virus. It was political. I heard that if you get the vaccine, it's so the government can control you. And the last theme that emerged was insecurity. Insecurity around employment and deportation shaped decision-making around COVID-19 testing. So the fear of a positive test result and the possible loss of employment, and then the potential fear of deportation. The idea that the individuals may need to share their information with healthcare professionals or public health officials. As one participant said, there's a fear that you can lose your job if you test positive for the virus. The migration situation is a barrier that makes it difficult for people to get tested. They fear that those at the testing service will share their information. So we see how economic, political, and social cultural factors increase risk for COVID-19 transmission and death within these particular farm working communities, and that mistrust in the government and fears of deportation due to anti-immigrant sentiments and policies create significant barriers to utilization of COVID-19 testing services and vaccine uptake among this particular community. So there is a need to engage those most vulnerable to COVID-19 risk, in this case, Latino and Indigenous farm workers, in decision-making around public health outreach and service delivery. Promotores are key community leaders and collaborators, and collaborations with them are critical to engaging Latino farm workers in COVID-19 continued testing and vaccination services. And I'd just like to thank my team. As you can see here, this is one of our outreach events. We have pláticas. We continue to have pláticas every Wednesday on our Facebook page. And if you are interested to learn more about the activity that we engage in, you can follow us on Facebook at Unidos por Salud and feel free to contact me. Thank you.
Thank you, Dr. Cheney. Our third presenter is Dr. Alicia Riley. Dr. Riley is a postdoctoral scholar in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. Her presentation is titled "A Demographic Analysis of Mortality Due to COVID-19 Among California Farmworkers."
How does that look? Can you see my slides now?
I don't see the whole slide. I see mainly the notes.
I see. You see my presenter view. Okay, helpful.
Yes, correct.
Let's see if we can switch it. How about now?
Yes.
Okay. Thanks so much. It's a real honor to be here, to be part of this conference and to see all of the amazing work and concern. I'm going to speak to you today to share just a brief profile on death due to COVID-19 among farm workers in California. So we are starting with the recognition that farm workers are one of the groups hardest hit by the pandemic. In California, some work by some colleagues and I showed that the food and farm work sector had the highest relative increase in death due to the pandemic in 2020. And this is because while others were able to stay home and work remotely, the essential work of farm workers continued, and it continued despite lack of protections in the workplace, despite access to healthcare and testing and treatment. And we know, as others have shared, that farm work is notoriously underpaid, lacking benefits, underregulated, with lots of exploitation and undermining of worker power. So this is setting the stage, really. This is a quote from a farm owner in Southern California during the pandemic. "We're harvesting a perishable commodity, but it's not going to stop growing for us to wait. It would be a major concern if we got to the point where we'd have to leave a crop in the field and walk by it over-matured. That would be devastating." And I bring this in to show the tension that exists between what the farm worker is pointing to, which is the devastation of crop loss and the economic devastation, and the devastation of human life loss. And what I'm talking about here is human life. And while the presentation that I'm going to give is going to feel dry because I'm going to show you a lot of numbers and percentages, I just want to take a moment to emphasize that each of these is a person who died too young, and they died a preventable death. So the data that I'm using for this study is death certificate data that was shared by the California Department of Public Health. The death certificate includes a field where for someone's occupation and their industry, and that's how we make a guess as to who are farm workers, because people can fill in whether they are field workers or farm workers, and then they're assigned a census code based on those two fields. And so I'm using the census code 6050 for all of this analysis, if you're familiar with that. And we limited the analysis to working age farm workers. So that's people 18 through 65 years of age. So just keep that in mind when you look at my results. And then the one other thing I'll point out is that a lot of what I'm doing here is thinking about what's the normal level of death that we would see in a normal year had there been no pandemic. And so we use 2018 and 2019, March through December of those years, as our comparison of that's a normal year. And then we compare it to the pandemic period in 2020. So I'm going to jump straight into findings for the sake of time. Now, this is the concept of excess death or excess mortality. It's a little confusing, so this visual should help. Basically, this grayish green bar, that's the normal level of death we would expect among this group of working age farm workers in California. And then the pink bar is the excess death, what was unusually high during the pandemic in 2020. And so this is a 56% increase in mortality among working age farm workers, and that's stunningly high. To give you a contrast, among farm managers, for example, it was only a 17% increase. So among field workers and farm workers themselves, we see a 56% increase. And this specific job title had the third highest relative increase of any specific job in California. This is just another visual of how it looks over the months, and you can really sort of see the harvest season come in here with the peak percent increases in death in July and August, with August almost over 2 times as much deaths in August there. Now, I'm going to zoom in on this excess mortality in the next slide. So let's just look at the excess alone. This is how much of the excess was officially attributed to COVID on the death certificates. And the main pattern you see here is that, number one, the majority of this excess is officially listed as COVID on the death certificate, but not all of it. And the patterns that we see here suggest that there is probably a lot of underdiagnosis of COVID. So now I'm going to jump into thinking about just a few of the demographic characteristics within the farm worker group to give a little bit more insight. When you see things in pink, that's usually referring to the excess mortality, and in green, it's the COVID-specific deaths. And so I'll just highlight that the majority of the COVID deaths were men. That is not surprising. That's about what we expected based on who dies in a normal year. The COVID deaths were older. So this is among working age people, so it's limited, but even among working age people, those who died of COVID were older than we would see in a normal year, and they were even more Latino than expected. So normally about 12% of the deaths that we see are non-Latino, and the COVID deaths, only 3% of them were non-Latino. Looking at education, we see that the COVID deaths are the people with less than high school, and especially less than a 9th grade education, were overrepresented among COVID deaths. And the other thing is that partly because so many people in that oldest age group, 55 to 65, were those who died of COVID, we see that they had really spent a long time in the job, on average 24 years in the job. Looking at place of birth, the main important pattern that I want to show here is that the majority of the people who died of COVID were born in Mexico. Now, that's not particularly surprising at first because we know that so many farm workers are born in Mexico, but when you look at it and you compare it to a normal year, you see that Mexican-born and people born in one of the Northern Triangle countries, Guatemala, El Salvador, Honduras, are overrepresented among pandemic deaths and specifically among COVID deaths. And so you can really see that pandemic mortality increased 62% for Mexican-born people, farm workers, 70% for Guatemala, Honduras, El Salvador-born farm workers, but only 43% for US-born farm workers. So this is raising questions about some of the vulnerabilities. And then finally, just looking quickly at where people lived at the time of their death. The pink bars here give you a sense of where the majority of deaths were in a normal year in 2019. And so you see the big counties, Kern, Fresno, Tulare, are the counties with the most farm worker deaths in a normal year. What's different about the COVID deaths is that counties like San Joaquin County and Riverside County are overrepresented. So they experienced a higher burden of COVID than we would have expected. So this just kind of summarizes what I just said. Older workers were overrepresented, Latinos were overrepresented, workers with very low formal schooling were overrepresented, those born in Mexico or a Northern Triangle country, and those in Riverside County, San Joaquin, and especially some of the smaller counties were overrepresented among COVID deaths. I can't get into why, but I want to really highlight the ways that the same intersecting structural disadvantages that contribute to the health disparities that are experienced by farm workers in normal times were just further activated during the pandemic and still are. And so we see so many of these intersecting. And that's precisely why more action is needed. If you take one thing away from my talk, I want it to be that these are preventable deaths. When I say that mortality increased 56% among working age farm workers, I want you to keep in mind that among white healthcare workers in California who are also working age, it only increased 2%. So 56% versus 2%. These deaths were preventable. And they are still preventable. And what we need to do is take action to ensure that farm workers have true access to vaccination. For example, at the worksite, this is a photo of a worksite vaccination back in January in Riverside. And then we need expanded worker protections. They matter. Worker protections, enforcement, true enforcement of workplace safety, not just paying attention to complaints, but true inspections and enforcement, really addressing the exclusion of farm workers from medical care, high quality medical care, addressing the exclusion of non-citizens from social protections of all kinds, including what it would mean to have a pathway to citizenship. And then really thinking about what it means for these communities to have lost so many breadwinners so young, and the concentration of this loss, and thinking about all the ways that support needs to be targeted at communities, financial relief, but also trauma support. So I'll stop there, and I just want to thank my collaborators and funders and all of you for your attention.
Thank you, Dr. Riley. Our final presenter